Hi, I'm Dr. Tony Mork, endoscopic spine specialist, and this is part 2 of annular tears. We're going to talk about evaluating the annular tear or making the diagnosis and how to do that. There are really two issues in evaluating low back pain. One, often you can't see an annular tear in the MRI, as we talked about in the first part of this presentation on the previous video. And two, you can't discriminate if a tear is toxic or painful or not just looking at the MRI scan, even if the MRI scan can show it. So most people kind of give up here at this point, and so people end up going to doctor after doctor, and they're very frustrated. They've tried physical therapy, acupuncture, chiropractic, but nothing seems to relieve their back pain, and worse yet, nobody can tell them what the cause is. So is there an MRI finding that correlates to an annular tear to prompt you to do something else? Yes. One thing that correlates pretty well is a disc bulge. There's absolutely no indication on this MRI scan that there is an annular tear here, but this disc bulge can correlate with an annular tear under the right circumstances, and we're going to talk further about that. So, as I talked about in the first video, a positive history, any of the questions of the Toxic 12, gives you a little indication that you may be dealing with an annular tear. When you combine that with a disc bulge on the MRI scan, you should be developing a higher index of suspicion that that might be the problem. So don't underestimate the history. It's very important for annular tears, almost more than anything else I can think of with respect to back pain. And disc bulges found on the MRI scan are common, particularly after the age of 40, and are often ignored because they just don't show anything other than the bulge, which is on the MRI scan not very impressive. But it can be an important finding with the right history. And the right history is some of the questions answered of the Toxic 12, like we've talked about. These examples of the Toxic 12 are telltale signs of a toxic annular tear. There are two dilemmas when evaluating a toxic annular tear. First dilemma is the annular tear seen on the MRI painful or not? So first you have to see it on the MRI and then determine if it's painful, which we've shown by some studies that it may very well not be. The second dilemma, is there an annular tear you cannot see on the MRI, which I think is very important and kind of reflects back on the bulges seen on the MRI, which we're going to talk about in a little bit more. So an accurate diagnosis is the key for a treatment plan, which we're going to talk about in the last video. Well, what is the best way to diagnose a toxic annular tear? The gold standard to diagnose an annular tear is a CT scan after a discogram. So this arrow here on the right-hand side is pointing at the dye that's moving out of here, and that is the annular tear. This was actually the same person as seen on the previous MRI, just showing a bulge. So we had no indication on the MRI that this was here, but this was the major source of her pain, and seen only after putting some dye in the disc and then taking a CT scan. Another benefit of the discogram is the provocative component. Well, the provocative component is what the patient gives you as feedback when the dye is put into the disc. So the dye is put in with some pressure, and then the patient can give you some feedback. If the pain is the same as their old pain or what they came as describing as a problem pain, the pain is called concordant. And if the pain is different than their back pain, it's described as non-concordant, or what I call new pain. Also, the pain assessment tool, on the bottom you can see that there's No pain is a 0, or 1 to 3 is mild, whereas very severe pain is 8, 9, and 10. The provocative discography certainly is not described as being perfect. People don't always talk about their pain either in location or in intensity very accurately, but it can be very helpful if they give a very conclusive type of description. So my sequence to diagnose the annular tears are to 1, take a history, 2, get an MRI scan, 3, do a discogram, 4, follow it with a CT scan when indicated. And here this is in the operating room. So a discogram is performed in a sterile environment in the operating room with fluoroscopic x-ray to place the dye. And there's before placing that, I don't think things should be painful for evaluating these type of problems. So there's a short-acting sedative without narcotics. So propofol is good because it just kind of puts you to sleep moment for just a few minutes, and it's got no narcotics to actually relieve any pain. So it's short-acting. You put the propofol in, place the needles in the disc, and then the patient is allowed to wake up. You inject some dye and listen for the response. That's either old pain, new pain, and what the intensity is. And I want to know 2 things at the time. I want to know, is it old pain or new pain? And then how bad is the pain? And that's the 0 to 10 scale. Then to recovery, and then to the CT scanner. The CT discogram is the gold standard for diagnosing an annular tear, and here are a few examples. Example 1 is this is the one we showed. This is actually looking at the left hand. We see the disc bulge here. Absolutely no comment on the MRI report of any type of annular tear. And the lady had chronic back pain after a motor vehicle accident. And here, here's the dye from the discogram, and then here we see the dye leaking out the back. Absolutely an annular tear, not demonstrated at all by the MRI scan. Here's example 2. In this case, we do see a high intensity zone here on the left, and the other discs look actually fairly good or okay. This is a darker disc, and we don't know if this is causing the pain or not, but we can see here that there's an annular tear here for sure, and it did correlate with this person's pain as well at L5S1. Example 3, again, here we have a disc bulge, and here we have a disc, actually a little small protrusion, herniation, and after the CT, we can see that the herniation didn't really give rise to any type of annular tear, but the level above that looked normal and read as just a disc bulge on the MRI scan is leaking dye out the back for sure. And here's the axial view, so we can see the dye coming straight out the back and a little bit over here to this side as well. Now we have a diagnosis. But the mystery remains. Why are some tears toxic and hurt while most tears don't hurt? What is the problem? What's going on here? There's really so many unanswered questions about why some of these things hurt. And who knows why some of them hurt? But the presentation is so variable, as indicated by the history and the 12 questions that seem to be positive in so many of the cases. So the diagnosis starts with imaging, X-ray, you might see some end plate changes, MRI, we can see the high intensity zone, HIZ, a dark disc, maybe modic changes of the end plates, then a discogram, provocative, annulogram means we put some dye into the periphery of the disc, and then follow it with a discogram, follow it with a CT scan. So MRI, high intensity zone, might see a dark disc, might see modic changes, might see a disc bulge, any of which can suggest an annular tear. The thing is, you have to keep in mind that the MRI slices are 3 to 4 millimeters, which may account for the negative MRI scan if the tear or granulation tissue is too small to be seen. The high intensity zone is a high T2 signal. There's a little white dot we saw on some of the previous films, and although initially it was supposed to correlate or predict, give a good predictive value for a painful disc on awake discography, other investigators were not so sure. So the original ones were very certain about it, but others could not really correlate the high intensity zone, which is easy to see on an MRI scan, with a painful disc. The high intensity zone just suggests a problem. It doesn't confirm it's the source of pain. So there isn't really a surefire 100% way to know that an annular tear causes axial back pain. Well, what's the problem? What causes the pain, given the fact that there are similar MRI findings in asymptomatic individuals? Well, there are two main issues, each with their own subset of problems. Issue one, the healing environment in a disc is not optimal at all. What's the healing environment like? Well, I'll give you a hint, it's bad. The bad environment is caused by 4 problems. 1, poor blood supply. 2, low oxygen content. 3, it's a low pH, it's acidic. 4, high tensile strains. In other words, the back is always moving, so it can't be held still to try to heal itself like other parts of the body can. Issue 2, free-floating fragments inside the disc. Well, the free-floating fragments can give rise to 3 different problems. Mechanical problems, number 2, chemical response to the fragments to try to resorb them, and number 3, an immunogenic sensitivity when the body responds to the fragments. Well, what about number 1, free-floating fragments, mechanical issues? What's the mechanical issue? This is, when I put a scope inside of a disc, these are the free-floating fragments. These are just floating around inside the disc. They're not anchored to anything, and it's usually a very sizable amount of material that comes out of these discs with a symptomatic annular tear. So here's the disc material here is from lumbar 3-4 disc, and here's one from lumbar 4-5. And you can see that it's almost 3/4 of an inch or an inch of just a pile of fragments, and these took no effort to get out. They just put the scope in, as we're going to show here in a couple minutes, and these just pile right on out. So loose disc fragments can get trapped in the fissures and tears, so the annular tears just can't heal. So they act as a mechanical problem. And how do I know this? Because I put an endoscope inside a number of discs and take a look inside. Well, how do you put an endoscope into a disc? Well, I use the transforaminal approach because it's safe. If we're looking at the spine from the side, we can see that the nerve is coming out of the central canal. There's the disc right there. And this portion here is the safe triangle described by Camden many, many decades ago. And it represents a safe entry into the disc. So it's below the nerve, so in order to avoid injury. And the fragments that are floating around inside the disc really look like a snow globe, but they're quite a bit larger. Inside the disc, I have stained with methylene blue to help visualize exactly what we're seeing. Now, this is the scope inside of a disc. And you can see that I'm not doing anything. These fragments are just piling out of here. The blue is from the methylene blue staining, and it's a acidophilic dye that stains the nucleus, nucleic acids of the dead tissues, so that anything you see here that's blue is dead. Now, again, we're looking in the inside of a disc, the vertebrae are to the right and left, And I'm doing very little here to actually just, I'm just teasing the tissue away, but you can just see how many fragments are just piling out of the inside of this disc. And it ends up to be a pile on the sponge like I showed you before. But the blue color is just so that you can see a little bit better. But you can see I'm really just very gently doing hardly anything. And look at all this blue material coming out from inside the disc. This is a classic annular tear. And you can see the tremendous amount of free-floating debris. So the body responds, again, chemically to the free-floating fragments here. And it also, the one thing is the disc may not be immunogenically privileged, so it can engender an immune response. So this is a picture of the fragments, actually probably more, but you can see them all stained blue, and this is exactly what's inside, floating around the inside of a disc with an annular tear. Very typical. And this is a small amount. This is just a very average amount. It can be quite a bit more than this as well. These fragments of the disc move in and out of the wrong place. And when people call me, they say, hey, my back just goes out. Or when you've heard people say, hey, my back just goes out, these fragments can move in and out of the wrong place. And the people's back will lock up for a day or so or 3 until the fragments can move into a better place. And then they say, oh, yeah, now my back is better. But now you can actually see the mechanical reason when people say, my back just goes out. Now here's an example. This is this is the back of the annulus. Now this, I'm going to show you a fragment of why people say my back goes out. So I'm kind of mobilizing a little fragment here, and you're going to see this fragment right below here. You see my little white arrow here. So watch this. I'm just mobilizing something, but watch the size of this huge fragment come out here. There, to see the blue, the stain, there's the fragment coming right out. There you can see it just popped out of the annular tear. So when people say, wow, my back goes out, this is why fragments like this are moving in and out of the wrong position. The annulus is hard to heal without the removal of the interposed fragments. I mean, you just, these are dead fragments of tissue. They're stuck in the fissures and fractures of the disc, and of course there's no way for them to heal if you've got all these loose fragments stuck in the fissures. Well, the free-floating fragments can also cause a chemical response. The body wants to resorb the fragments because they're actually not helping, they're non-viable, they don't help anything, but the fragments can't get out, and the metabolism and all the blood supply to the disc is very poor. So the attempt to resorb them is pretty slow, and unfortunately the fragment breakdown generates some very inflammatory byproducts, such as cytokines, bradykinins, TNA alpha, all of which generate inflammation at the edge of the disc and the annulus. And actually sometimes can leak out, and this is how I believe people can get leg pain without having a disc herniation. These inflammatory byproducts leak out of the back of the annulus and can stimulate the nerves going down to the legs and into the hips, groin, genitals, etc. Number 3 problem with the free-floating fragments. The fragments of the nucleus may not be immunogenically privileged, which means that an immune response can also be generated to the disc fragments. And this immune response can cause a sensitivity. So here we have the immune response to the disc, the inflammation of the annulus, and the disc fragments. So the annulus is sensitized, and the inflammatory mediators sensitize the nocioreceptors, which are sensory nerves accompanying the small healing blood vessels. So as the annulus is trying to heal itself, you get the little sensory nerves that accompany the blood vessels, and they can become very sensitized to pain. Well, thank you very much for watching part 2. If you've got any problems, questions, please don't hesitate to call or click onto the website. And please stay tuned or take a look at number 3, which is the treatment of annular tears. Thank you.